and we'll put those on the screen. One is through your computer, go to pollev.com, and Mr. Producer will put that up, pollev.com, enter DeBakey, and then respond to the activity. If you want to join by text from your phone, go to 37607 and text DeBakey. So, Mr. Producer, now you got it up there. Thank you. So if you're on your phone, go to 37607, text DeBakey, put in your message, your question. If you're on your computer, go to pollev.com, enter DeBakey, and then ask your question. I recommend that you ask your questions earlier in this hour so that we don't have a barrage at the end where we may not be able to answer all your questions. If we get your question in time, we will do everything we can to answer your question. You may have a question from my guest, and that's fine too. The question can be for either me or the guest. It's towards the end of the year. I'd like to take this opportunity to thank the producers here at DeBakey CV Live for keeping this live, and I know it's appreciated by a lot of people who joined this webcast live, but also watch it after the fact. If you see this after the live show, the producers have set it up so now you can still ask a question, and we will answer your question on the following show. So if you have questions watching this and it's not live, you can still turn in your question, and we'll answer your question next webcast, which will be first Tuesday in February. So that's a nice little addition that we added about 6 months ago. I'd like to also thank the people that do all the hard work in the office, Kimberly and Christina. We have worked very diligently this year to catch up with the backlog. At one time, we were backed up almost close to a year with patients waiting. We have cleared that backlog. Our wait list now, if someone is interested in the Wolf procedure and is a candidate for the Wolf procedure, the wait is only about a month or 6 weeks. So we're very proud and pleased and happy that we've taken care of the backlog. And I'm not sure that's out there. So for those of you who see that it's a 8-month wait to do the procedure at Houston, that's no longer true. Now it's only about 4 to 6 weeks. And if you have questions, if you'd like to get a consultation, all you have to do is call Kimberly or Christina, 713-441-9342, or simply go to the website, Wolf Procedure, and there's a place to respond there, and we'll be happy to set up a meeting. These meetings don't mean that you're going to have the procedure, but it's a good opportunity to see what your options are. Dr. Miranda has been monitoring the website. I also wanted to thank him for his tireless work on that over the last couple of years. So if you have questions or you want to schedule a meeting, a consultation, a second opinion, you can also go to wolfprocedure.com, and it's pretty easy to schedule it. I'd like to cover a couple of questions before I introduce Bill. And the first one is pericarditis. I think a lot of this comes from the Facebook page. Another thank you is due, and that's Sandy Schremeyer, who had this procedure, I think it's almost 7 years ago now, after 3 failed ablations. And she took over the Facebook site and took it from very few people, I think over 3K now, 3 point something K. And that's mainly because of her. She's done a great job, and we should all thank Sandy for the help that she's given to so many patients and potential patients and past patients. So some of the questions sometimes are things that come up on the Facebook site, the Wolf Procedure Facebook site, Live AFib Free. Now keep in mind, There are a lot of people who don't use the Facebook site that have had this procedure. But generally, if someone is having an issue, then they will be on the Facebook site. So the Facebook site questions come from a small percentage of people that may be having some issues. And I'm fine with that. That's okay. But I don't usually give advice through Facebook because I don't think it's probably a good idea. But here's a question. Can you explain pericarditis? Yes, I can. Pericarditis means inflammation of the heart sac. So all mammals, whether you're a squirrel or a raccoon or a human, have a sac around your heart. That's a protective sac. It inhibits bacterial infections, viral infections, creates some lubrication for the heart. And that's called the pericardium, which simply in Latin means around the heart. Peri, around, and the heart is the cardia. So pericarditis is inflammation. Itis means inflammation, so it means an inflammation of the heart sac. Inflammation of the heart sac, which can occur spontaneously in people that are sick, but it's also known to occur anytime there's been any entry into the heart sac. It happens about 5% of the time after open heart surgery. It can happen about 5% of the time after the Wolf procedure. Any procedure where the heart sac is opened, whether it's closed or not, we do close it, but there can be inflammation, and that's called pericarditis. Now, fortunately, the treatment is to decrease the inflammation. And we do that proactively with the Wolf procedure. After the procedure, patients are given prednisone, a form of prednisone in the IV, and then we use oral prednisone, Medrol dose pack. We also use an anti-gout drug, coltracine, and that dramatically decreases the chances of inflammation around the heart sac. But it still can occur. We don't know exactly why. Some people get it and some don't, but 95% of people don't get it. But we hear a lot about those who do get it. Generally, it's something that occurs about 4 to 6 weeks after heart surgery, after someone's been doing quite well. They suddenly have chest pain, discomfort. They can have fever. It can be difficult to take a deep breath. And it's treated very nicely with anti-inflammatory drugs, and usually the symptoms are gone in 48 hours. That usually takes care of it, but it can recur, and we have seen that from time to time. One of the good news is we now have a pericarditis clinic at Methodist. Methodist does over 1,500 heart procedures a year, so now there is a clinic here for that. So if you have recurrent pericarditis, we have another option for you with some experts here that do this. Another question that came up was on discomfort in the breast after the Wolf procedure. There are little nerves that run up under the skin. These are the first ones to be irritated and the last ones to come back to normal, and that can be quite troublesome. It's unusual. You can ask Sandy Schremeyer. She never had any pain at all. Most people don't, but some do. I do put nerve blocks in at the time of the procedure, which also decreases that breast discomfort. It's best treated with topical treatment like Salonpas or pain pills, but the best treatment seems to be the Motrin or Advil. That's the best thing for that discomfort. But it's usually irritation of the little nerves that are right under the skin. Okay, so we did some questions. We took care of some thank yous. And Bill, you've been kind enough to stay on the line here and wait for your introduction. What I asked Bill to do is to give you his story. I may interject from time to time to make some points. But Bill, I want to welcome to the program to DeBakey CV Live. Thanks for taking a little time out. And you told me earlier you're back home around near Sacramento. So why don't you just start out and tell us your journey of AFib.
Okay, well, I'll start with, my age. I'm 68. and I'm a retired fire chief from a large district out here. I've worked 36 years in the fire service, and that included well over 1,000 midnight calls
Thank you
and
for
a
your
lot of
service, by
adrenaline
the
during
way.
that time.
Thank
What's
you.
that?
Thank you for your service.
Oh, my pleasure. I enjoyed it
Yeah.
every minute of it. On to my history. I've had 7 ablations total. I guess if you want to consider the Wolf procedure a part of an ablation, I've had 8. I'm currently 9 months Wolf procedure, post Wolf procedure, and I got to tell you, my heart feels invisible again. I haven't. I've dealt with arrhythmias for over a quarter century, and my heart hasn't felt this normal since 1997. So anyway, on to my history. Anything I say is not medical advice. Talk to your doctor, please. But I do have opinions on a few things. My first excessive arrhythmias were noticed in 1997, and I was I'd had a few for a few months, and they weren't a lot, nothing too concerning. And then one day I was working at a fire station on overtime, and I started having 30, 40-minute PVCs a minute, which is quite a few. And I put myself on the paramedics monitor, and my paramedic caught me, and he called my battalion chief, and battalion chief found out how many I was having and sent me to the hospital. So that's how I got evaluated for the first time. It wasn't AFib at the time. It was just an excessive amount of PVCs. And I dealt with that for the next 11 years, talking to one cardiologist after another, trying to get some solution. And I did not have 30 or 40 all the time, but I had episodes of that. And I had more than you that is comfortable a lot of the time. But they put me on different meds, notably atenolol and a host of others. And I went through several cardiologists over the next 11 years, experimented with different medicines, lifestyle changes to try to control the excessive PVCs and PACs. You know,
After 11 years, is that when you started having atrial fibrillation?
right. And I got pretty adept at noticing those irregular heartbeats. So I'm one of those people that notices it. So I noticed it AFib when it happened. Um,
Well, that's an
so
important point because we did a study on that published in 2007 Annals of Thoracic Surgery. We had people wear monitors, the old-fashioned monitors, and keep a diary, and then we matched their findings with what we saw on the monitor. And about half the patients knew exactly when they went out of rhythm. They could tell you the beat they went out, and they could tell you the beat they went in. I guess you're like that.
yeah, I would say 90% of the time I could tell.
And then the other
And most of my
50% of the
AFib
people,
occurred in the evening, during
mm,
sleep. So probably, related to CPAP issues. But I
well,
did,
there's another point of that, and that is people generally feel them more at night because they're not distracted.
yeah, that's true.
And then the other 50% of the people in the study, Bill, they really never could tell when they were in or out, other than the fact they were a little more tired, a little harder to get up a flight of steps, maybe a little more short of breath at the top of the steps, or maybe with some of them, they would get dizzy from time to time. But it turns out the dizziness is usually when you go back in rhythm. So when your heart goes back in rhythm on its own, generally there's a pause. And during that pause, there's no blood going to your head, just for a few seconds, and that can make you feel a little woozy. I don't know if you ever had that.
Yeah, I don't know if it happened when I went back into it, but I definitely felt woozy a few times
Yeah.
um, while
Well,
I
so
had the
Chief,
AFib.
I guess you probably experienced a little stress from time to time, didn't you?
Yes, once in a while it did occur.
So I still believe firmly that a lot of this is stress related, and it's related to the nerves, and the nerves are on the outside of the heart. So even in somebody who's had 7 ablations, those are all from the inside of the heart. There are no nerves on the inside of the heart. So the chances of really taking care of all this is pretty small. Whereas if you're on the outside of the heart, the nerves are right there, and you can do what we call a partial cardiac denervation, which is what the Wolf procedure is. It doesn't take out all the nerves, but it takes out enough of these autonomic nerves to quiet the heart. And what a lot of people tell me is after this procedure, they feel like their whole demeanor is a little better. They're just a little more calmer. Have you heard that?
I feel that. Like I said earlier, I haven't felt this good in over a quarter century. So I definitely feel like, after maybe a month of getting through the procedure and all that, you really start feeling great, in my case anyway. So
how did you tell us how you got from 1 to 7? I mean, you wouldn't have your
well, I wish I'd have found you a lot sooner.
You wouldn't have your gallbladder taken out 7 times.
I was diagnosed in I think it comes from me wanting to find a cure, and then the EP wanting me to he to his favor wanted me to get off meds. And
were you still working at the time? Were you still working at the time?
Better. I was.
Okay.
I worked for a couple more years after I was diagnosed with AFib.
So you're working and you're getting an ablation.
Yeah. Well, I didn't get the ablation until 2011, shortly after I retired. But yeah, in 2009, I came down with the AFib, and then on to cardiologist again. Eventually, I got referred to an EP, and the first thing he did was recommend a ablation for the PVCs. Now that, I know you're not a big fan of ablations, but that cured my 30 or 40 PVCs. I've never had that since that first ablation. And then 3 months later, we did the first AFib ablation, which, I don't remember if I had some during the blanking period, probably. And then maybe 6 months to a year and a half, it was much better. And that's kind of what reoccurred each time. And they were all symptomatic to me. I could tell when I was in AFib. You talked about lethargy, that hits you immediately. And, those times when you didn't know you had it because you're busy, you all of a sudden feel tired when you shouldn't be tired. You go, okay, time to get the cardia out and check it. And I experimented with all kinds of the Chinese versions of the cardia before the cardia came around, and was very good. And they are helpful. And it was always nice to have the paramedics at work that could throw me on the machine.
Now, around
the time I got diagnosed with the AFib and, between the first procedure, they put me on a CPAP machine. It took me a couple of years to start using that religiously, which probably wasn't good, but I suspect that's what everybody goes through. It's pretty hard to adapt to, but once you get through it, I think it's absolutely essential to keep using that CPAP.
That's a good point. That's a good point. If you, Mr. Producer, put the ways to reach us up again, if you would. The computer, and then also the on your phone, smartphone. Just while we're talking here for a second, again, I want to emphasize we're getting some questions. If you want to get your question answered by me or by Bill, please enter your question now. Don't wait till the end of our webcast. Now, Bill, I assume that during this time that you're going through these ablations, from time to time, at least, you were probably on antiarrhythmics as well. Is that true?
Yes. Yes.
And did those help?
I suspect they helped, but the whole goal was to get off the antiarrhythmics. And once I started getting off the antiarrhythmics, it would come back.
That begs the question: were the antiarrhythmics keeping you in rhythm after an ablation, or was it the ablation?
Yeah, I don't know, but the goal from my EP was to get me off those, because he knows that they're not good for you long term, and it was also to make sure your heart doesn't stay out of beat and your atrium doesn't enlarge too much. And aside from the negative impacts of the ablations, that kind of worked for 11 or 12 years. Yeah. And I was game to keep trying it. He told me initially he'd only do 3, and he kept caving, and he kept doing more. And I think you and I talked about my CT, and it wasn't too bad. The damage around the pulmonary vein, I think, is moderate.
Yeah, you did.
It could have been worse.
That's a good point. As I recall, you had a 35% stenosis of both the pulmonary veins on the left side, which is usually where we see the pulmonary stenosis means there's a narrowing of the vein. And the reason that occurs, these veins are very fragile. They're almost like saran wrap. So when you heat them up with radio frequency, they shrink like saran wrap will shrink if you heat it up. And that's kind of the effect you see. You see a heat shrink around the vein. I've seen it at 100%, which means it's occluded. 35% is okay. And they're very hard to fix. It's a very bad problem to have if it's more than 60 or 70%. It's usually on the left side because when a catheter ablation is done, the way it goes into the left atrium, it's a straight shot at the left veins. So they usually take the bulk of the heat straight on, can really burn them up. To do the right veins, you got to do a 270-degree turn and go the other way from where you came in. So it's harder to get right up against the vein and get as much heat as you do the right. So generally, although I have seen 90% stenosis on the right too, so something you have to be careful for. And that is the reason in patients like you that we really want to do a CT scan pre-operatively. Because if there is some blockage, we'd like to know where it is and how much it is, because it can affect what we're able to do. So let's see, at some point you got up to 6 or 7 and the light went off, Chief. What happened? How'd you?
Well, the last one I got, my last return of AFib and then was flutter. Flutter hit me in 2023, and then we did one final ablation to try to resolve the flutter, which was unsuccessful. I mean, it worked for a while, like all the others. It works for a while, and then it comes back. But flutter was less symptomatic for me, and I was able to control the heart rate. But I had most of my cardioversions were after flutter. I think I only had that one initial one in 2009, and I had maybe 1 or 2 throughout that whole 11, 12, 14-year period on AFibs. Usually I would auto convert. If I would notice I'm in it, I would, take the maximum dose of the antiarrhythmic I was on, typically Rhythmol, and that would pop me out of it within 6 to 8 hours usually. A few times it went a day or two.
How many cardioversions, ballpark figure, do you think you've had now?
Counting, you had to do one, right?
Yeah.
Probably 5. Not too many for that long a period, I think.
Yeah. Okay.
I'm pretty lucky.
What do you
I
think?
auto converted most times. It was the flutter was the most challenging, and probably 3 of those were flutter.
Well,
3 were flutter.
You bring up an excellent point. The most common abnormal rhythm after a catheter ablation is flutter, and it's left atrial flutter, which we hardly ever saw in the real world until ablations. Most flutter is on the right side, and the flutter, for those of you who aren't familiar with it, is where the top 2 chambers are beating, but they're beating way faster than the lower chambers. The lower chambers may be 70, 80, 100. The top chambers may be 300. So the signal degrades as it goes down deliberately. Our bodies are made that way, because if your top chambers were going 300 and everything got down to the bottom chambers going 300, you would definitely be passed out on the side of the road. So with fibrillation, the top 2 chambers are not beating, they're just shaking, wiggling. But in flutter, they are beating, but way too fast. But that's a common problem with treatment of AFib by catheter ablation. The good news is, and we found this out really by chance, that the Wolf procedure stops most of that too, and it stops yours. And the reason is it's still mediated through these autonomic nerves, which again are on the outside of the heart, not the inside of the heart. So it's a whole different way to look at AFib and aflutter and say we should go for the nerves. It's a nerve problem. Burning up the inside of the heart's not the answer. And I think you're sort of proof to that point, to that hypothesis.
I wish I had heard about you a lot sooner. That's for sure.
You wish
And
you
I'm
had what?
grateful that my heart hasn't been damaged that much.
Yeah.
And
Yeah.
I'm enjoying life.
Well, let's take
I don't know if you remember, but when we had the initial consult, I was only a month out from having that first ablation or that last ablation.
and I
And you
probably
told
told
me,
you you
well,
have to wait at least 6 months, right?
You told me I had to wait 6 months at least, and we're scheduled for. You said, let's go ahead and schedule a year out. You can always cancel if you feel like your last ablation worked. Well, it didn't,
Yeah.
of course. And flutter
Thanks for
returned.
bringing that up, because there are two reasons. I don't know if I stated them clearly to you at the time, but there are two reasons to wait. One is maybe things will settle down and it'll work. I mean, you hope. The second reason is things are pretty irritated in there after an ablation, and it's not safe to go in and work on the outside until all of it's settled down and it's scarred in and it's safe, and that's about 6 months. So those are the two reasons to wait before we go in for another procedure. Let's take a few questions here. And again, people who are watching this, you can send your questions in now. If you're viewing this after the live procedure and you've seen this on DeBakey CV Live when it's not live, you can still send in your questions and we'll answer them at the next webcast. Atrial flutter seems common after the Wolf procedure. How does a flutter, I guess you mean, differ from AFib? Will flutter show up on my link recorder? Okay, well, as I mentioned, with flutter, the top chambers are beating, but they're beating way too fast. When I look at the link, the implantable monitor, I can usually tell the difference. Kimberly can usually tell the difference. But the algorithm for the link is not very good at telling the difference. So usually the link will say AFib, and Kimberly and I will look at it and we'll say, no, that's not AFib, that's aflutter. So we can tell, but the current algorithm for Medtronic is not very good at telling that. It misses it more than 90% of the time. I think that'll change with AI and there'll be better diagnostics. But right now, if someone just reads your link and says you're an AFib and you've had ablations, it's probably not AFib, it's probably atrial flutter. It doesn't occur that often. It occurs more often after the Wolf procedure in people that have already had ablations. But it can occur in patients who've never had an ablation. But that's unusual, but it can. Fortunately, it's been very amendable to initially just a cardioversion, which is what you had, Chief. You had a cardioversion that took care of it. But if that doesn't take care of it, 6 months after the Wolf procedure, here at Methodist, Dr. Joe Fahed has been incredibly successful at going back with a catheter and finding some rogue spot that can be treated very nicely from the inside, some leak, if you will. He's been very successful. He's been successful in people that have been out of rhythm for years. In fact, we're probably going to write that up because the results are really pretty fantastic. So it's amendable to what we call a hybrid procedure, do the Wolf procedure, and if that persists, have a catheter ablation. That's the hybrid approach. But I don't do it for everybody because most people don't need it. You can go to certain places in this world and they'll say, we offer you the hybrid procedure, but every patient has to get the surgical and the EP procedure both. Why? If you're in rhythm after one of them, hold off on the other. Wait and see. In our case, 90% of those patients never need the other part of the procedure. So why do it in 90% of patients that don't need it? So we say wait. If you need it, fine, but if you don't do it in everybody. Here's another question. I had to get a cardioversion a month after the Wolf procedure. I'm in normal sinus now. How long a time will it take before I can be pretty sure that I'll stay this way? Well, it depends. One thing that I look at is the size of the left atrium on the CT scan, which I think you had preoperatively as well, right? I don't think yours was terribly enlarged. I think maybe your left atrium was 150 ml, something like that. You may not remember that, but it was. If it's less than 200, we have a good shot at success. If the left atrium is enlarged so much that it's over 200 milliliters, then the chances of success start to go down. It also depends on what type of AFib the patient had going into this. Were you in rhythm going into this, Bill, or were you out of rhythm?
I was, but I had been in flutter a few weeks earlier.
Okay, but still, you still had episodes of normal rhythm. So that increases the chances.
I was in full NSR when I got to Houston, and I've been in NSR ever since. And
okay,
it just feels different now. It feels calmer and better.
So we say the blanking period for what we do is probably the same as the EPs, which is 3 months. So after 3 months, if you're staying in rhythm and you're not on antiarrhythmics, then you should be fine. Amiodarone wears off very slowly, so you can get amiodarone effect for a couple of months after stopping the medication. So if you're on amiodarone, you're probably pretty safe that you're going to stay in rhythm if you're a couple of months out. Now, Bill and I were talking about this before we went on. Throw all that out the window when you add COVID vaccines and COVID disease. And as I was saying before to Bill, I saw some patients during COVID that were 14, 16, 17 years out from the Wolf procedure. No arrhythmias, no medications. And 2 or 3 days after they got a COVID shot or after they got COVID, they went out of rhythm. So I think you've heard these stories about COVID causing inflammation of the heart. I'm sure that's true. I'm sure that's true. And it wasn't just getting COVID, it was people getting the COVID shots too, the vaccine. It was both. So that's not my area of expertise, but certainly I think that disease and those vaccines caused inflammation of the heart, myocarditis, and that led some people into arrhythmias. The good news is usually if you got cardioverted, you were okay. Hi, Bill. This is Jerry and Lisa here watching you tonight. Your same day surgery anniversary buddy. You're looking great. So do you know who that is?
That's my twin. That's Jerry. Yeah. Yeah. We had dinner with them and we walked with them, and yeah, I remember Jerry. Absolutely. Hope he's doing great.
Yeah.
Good to see you both.
So what is the protocol for people that get flutter months after the procedure? Well, the first thing is to document it. If there's a link in, it'll be documented. If not, documented by an EKG. And then oftentimes I'll start an antiarrhythmic, maybe a different one. Sometimes if I notice that the patient had a very large left atrium before the Wolf procedure, or if they had been out of rhythm continuously for more than a year before the procedure, and send them straight to Dr. Fahed for a consultation. Fortunately, he does the virtual visits, and so it's really a second opinion, and he can tell patients whether or not they should try an antiarrhythmic or should they go straight to a hybrid follow-up cardiac ablation. And again, it depends on things like how bad was the heart, how long was the patient out of rhythm, before decide whether to do an antiarrhythmic and a cardioversion or go straight to an ablation. Let's see. I have hypertrophic cardiomyopathy, non-obstructive. Both of my EPs are recommending ablation for my AFib to hopefully get, and then maybe that's as much as you could get in there. Well, we've done many patients that have non-obstructive cardiomyopathy, and they do fine. So you can have an ablation. You can also have a Wolf procedure. If you're not sure which you want, you're welcome to get a consultation as a second opinion with us. I'm happy to give you that. You can go to the Wolf Procedure site, or you can call 713-441-9342. That's 713-441-9342. Or just go to the Wolf Procedure site, and there's a place there to turn in your information. We'll get you set up for an appointment, give you a second opinion. They're really two different things. You can have both, but I don't think they're related. And catheter ablation can work, but we do know that the results of the Wolf procedure are not 5 or 10% better than a catheter ablation. They're 100% better. We are doing a retrospective study now. We're very fortunate to have one of the medical students who was here 3 years ago, who's now a cardiac surgery resident in Budapest, Hungary. He's here for a year, and he's looking at 500 Wolf procedure patients who have the implanted monitor like the chief has. And we're going to get some very interesting data at 3 years on these patients. So that's ongoing now. Stay tuned. There'll probably be several publications coming out of this information. What's different about it? One, it's the different approach. It's the epicardial approach, the outside approach, instead of the inside burn the heart up approach. And secondly, all these patients have an implanted monitor, 100% of them. So we get an EKG every day. We get a readout every month. What's the AFib burden? So as far as I know, this has never been done before, and this will be some very important data going forward. Let's get back to you, Chief. You had the procedure. What's your overall feeling? Here's someone who's had a lot of experience with ablations, and now you've had the surgical procedure both. So you're someone who can speak from experience. Give us a rundown on the difference and overall.
Well, you've got a recovery from both of them. Your heart is definitely inflamed in both of them. There's no doubt that the Wolf procedure is more intensive. I was amazed at how well I felt a couple days in. I mean, from the moment I woke up, to be honest, I didn't feel bad. I never felt any incision pain ever. So you're a miracle worker to do all those incisions in somebody, and I never felt any pain out of those. The only, I did have some fluid that leaked out after we cut the stitches, and I dealt with that for a few months afterwards. But if anybody has that too on their right or left side, it will go away. Just check with your doctor and make sure everything's good. And it just like Dr. Wolf told me, it abated as time went by. It didn't fully abate till maybe 6 months, but it never bothered me. It was just a little bit of fluid.
Well, the fluid, there's naturally fluid around our lungs. It's lubricating fluid. And believe it or not, we turn over 1 liter of that a day, normally. Turn over 1 liter a day. That's like getting an oil change every day.
Yeah.
And it's unusual, but that is one thing that can happen. One of those can stay open because we do have these ports in. One of those can stay open. It's usually from where the chest tube was. Is that where yours was from?
Yeah, it's exactly where it was. The chest tube on the right
that's
side.
A straight in hole there.
Yeah.
And usually they're closed in a week, but as you pointed out, it can be a lot longer than that. And a little bit of that fluid that you're making every day can come out. It's best for it to come out if it's there, really.
Exactly.
You don't want to.
I felt very good after the procedure. Obviously there was chest pain. I was used to that from post-ablation, so I didn't freak out and think I was having a heart attack just because I had some mild, weird.
You just brought up another important point. Let me interrupt you. That you brought up a very important point. I can't tell you how many patients have had some when the numbing medicine wears off, and they go to the ER because they think they're having a heart attack or something. Almost every patient that we've done has had the CT scan pre-op. And the CT scan that we do is very specific, and it shows the coronary arteries beautifully. So if you come to Methodist and you have the pre-op CT scan and I tell you that there was no significant coronary disease, you can bank on that. Now, when you go to the emergency room after the Wolf procedure, they'll say, oh, your enzymes are elevated. Well, they will be, but it's not because you're having a heart attack. It's because you had heart surgery. Anything will elevate those enzymes. So in the emergency room, they may get very excited because you have elevated enzymes, but that's just from having the procedure. If your CT scan was okay and you didn't have coronary disease a day before the surgery, guess what? You don't have it a day after either. So for those people out there that are thinking about this or have had it, you're not going to have a heart attack after this procedure if your coronaries were cleared on the preoperative study. So that's a good point. Thanks for mentioning that. Tell us about how you're doing today. You kind of back to normal? Whatever that was?
Yeah, I'm very normal. I ended the amiodarone at the end of August. And probably a month or so after that, I noticed a slight uptick in PVCs, but way under 1% on the link. I think it's like 0.5 or something like that. They don't bother me. I feel great, and I've noticed over the last 9 months that the first few months, if I live on a hill out here. So when I was climbing up and down the hills, I'd have to stop and rest a little bit. It takes a while for your heart, in my situation anyway, to get back to 100% normal in it. And I suspect that's still going on probably for a year until everything's, completely back to normal, I hope. So,
what advice would you have for people that have failed ablations and people maybe that haven't had ablations that are trying to decide what to do?
I would absolutely not recommend someone to do any more than one ablation. If they feel like they want to do the ablation, then I guess go ahead and do it. It might cure you. In my experience, it probably won't. It's probably not bad for you. I hope not too bad. But I would recommend doing what my twin did, the same guy that you operated on, Jerry, that day. He was a one and done. So you had a good example that day. You have a guy that really overdid the ablations, and you had Jerry who was smart enough to get it done one time and then live good forever. Yeah. So I wish I was in his camp, but I'm happy for him. So my advice would be to do all your research, look at Sandy's Facebook page, look anywhere else you need to, consult with you, Dr. Wolf, and come up with a plan. And it was not near as bad. You think of it as being an open heart surgery, which it kind of is. You're not going in, but you're going minimally invasive. And it's scary. It was not that bad. It really was not that bad. I know people do have some complications. I had a couple, but nothing was terrible, and it was all dealable. And I was up walking in less than 24 hours. I was walking around to different parks and whatnot. I take it easy. I'm not one of these people that took off doing marathons afterwards. But take it easy. And when you need to stop and rest. Don't, kind of monitor your heart. I mean, Jerry clued me in on a Fitbit, so I still wear a Fitbit. So thanks, Jerry. And I, if my heart rate starts getting high, then okay, it's time to back off a little bit. And I haven't had to do that for months, but the first 6 months, you probably need to watch that pretty close and don't do anything dumb. I did one thing dumb while we were traveling. I didn't mean to, but our flight home, like 7-8 days post procedure, and we got a delayed flight out of Houston. Well, I had a really short connection. So between the low oxygen you get from being on a plane and having the operation probably, and then the adrenaline, trying to reach next to the gate, I would have never made it if my wife hadn't dashed down there and Delta was nice enough to hold it. But I felt like I was in a collapse, and I was barely walking. Yeah. Yeah. And don't mix adrenaline with recovery. That'll be my recommendation.
That's right. I'm going to take one last question here because we've gone 45 minutes already. Is Abbott Merlin better than Link at diagnosing flutter versus AFib? So this question relates to the fact that there are several different implantable devices to monitor your heart. I like the Medtronic Link, L-I-N-Q, but another one is the Abbott Merlin, and Boston Scientific has one too as well, and Biotronic has one. So I know of 4 companies that make these, and I have used some of the Abbott Merlin. The problem with the good thing about the Abbott Merlin is the battery lasts longer, but the Medtronic's 5 years. That's pretty good. The downside, though, is it doesn't take your EKG every day, and that's why the battery lasts longer. So I don't like it as much because if its algorithm decides that the heart's not out of rhythm, it doesn't do an EKG. And as I said earlier, a lot of times the algorithms for these are not very good at flutter. So if you have a very regular flutter, it may just say, well, your heart rate's a little bit high, but you're in rhythm when you're not. So I prefer the Link for that reason. Specifically for diagnosing flutter, I think the Link is better because I can see that EKG every day and make my own determination of what's going on. Whereas if the algorithm on the Abbott Merlin says everything's copacetic, it won't take the EKG, so there's nothing for me to see. Now I can request the patient to do so, but it's a little more convoluted to find out what's going on. So that's my answer to that question. Last point I want to make is that there's a newer treatment with ablation. It's a newer energy source called pulse field ablation. I don't know if you had any of those. You may not have. Probably didn't.
I did not.
No. But it's being touted as the next best thing since sliced bread. But the midterm results, that's where they take people that have had this newer treatment with pulse field for ablation versus standard radiotherapy, RF ablation, or even freezing ablation with cryo. The midterm results head-to-head didn't show any advantage to the pulse newer energy source, which I predicted because they're still going for the inside and not the outside. The EPs like it because the newer energy source, pulse field ablation, is much faster, so they can do more procedures in a day, and it may be safer. Not sure yet, but it may be safer. So you'll hear a lot about pulse field, but keep in mind the midterm results, in other words, percent of patients that are AFib free, is not any better than the old technique. Chief, I want to thank you for taking some time out to talk to people. I'm sure they'll find this helpful. If they would like to get a hold of you personally, are you okay giving them an email if they want to reach you?
Yes, my email is my last name, Sponable, SPONABLE 98 at AOL.com. Yep, I still have AOL.
AOL.
And I want to say one last thing, Dr. Wolf.
That's back when the dinosaurs were still out there.
I want to thank you and your staff. They were exemplary. I've never had better medical care than I was back in Houston. And I want to say, Dr. Wolf, you're making the heart great again. So I really appreciate it, and keep up the great work.
Well, thank you, Bill. And for those out there, remember that it's not spoon, it's Sponable. There's only one O, right?
Yes, that's true. Spoon is often a mispronunciation of my name.
SPONABLE 98. Is that right?
Yep, 98.
98 at AOL.com. Okay. Well, listen, I hope you had a good Thanksgiving. I hope you have a great Christmas. Thanks for sharing your journey with some people. You're probably kind of paying it forward now. We all appreciate it.
Well, I hope it was helpful, and thank you very much.
And thanks for all your service for all those years, too. Take care.
All right, you too. Bye-bye.
Bye-bye.